We're going to start the next session on inflammatory bowel disease. I think everyone knows that we're in the midst of an epidemic, a worldwide epidemic of inflammatory bowel disease, particularly in the developing world. But here in the developed world, it's been a long time issue. And fortunately, here in the Twin Cities, we're blessed with several talented gastroenterologists and a robust GI community, which we work collaboratively with. I'm Mark Osborne. I'm one of the partners down on the south side, and it's my pleasure to moderate this session. So first up, we have Dr. Byron Vaughn. Dr. Vaughn is a faculty at the University of Minnesota. He did his training in Boston at the Beth Israel Deaconess Medical Center, and he's going to talk to us on how much medical therapy is too much therapy. Dr. Vaughn.
Thank you. It's a pleasure to be here. Hopefully this will be an informative discussion. Obviously, the answer to how much medical therapy is too much is 3. So if you remember one thing, it is 3. Some disclosures, research support, and some speaking consulting. We won't really be talking about any specific therapies much. My overall goals for you today are to, one, for the obvious, state the goals of surgical therapy in IBD, but then to really identify some patient-related factors for both ulcerative colitis and Crohn's disease that may suggest an earlier surgical intervention. And lastly, to appreciate the importance of a mechanism of loss of response to guide subsequent medical therapy for who might benefit from moving to surgery after one drug or who you might want to really maximize medical therapy on. And I think big picture, having a framework for approaching this question is the right way to do this. There's obviously not going to be a single answer for every single patient, but you need to be thinking about it in the right way and asking the right questions. So one slide on the epidemiology and burden of disease. We're now up to about 3 million people in the U.S. with IBD, and that's updated based on, they changed the way they measured the prevalence a little bit. It used to be around 1.5, but it's now 3 million according to CDC. Of those people, we think around 20 to 30% of those with ulcerative colitis will ultimately go to surgery, and up to 80% and occasionally even 90%, depending on the exact literature looking at people with Crohn's disease, will need at least one surgery. Interestingly enough, despite surgical and medical interventions, the overall standardized mortality ratios for IBD is normal. So these are people who are not dying, but many of them are getting surgery at some point in their life. You can't have a slide on IBD therapy without seeing the traditional pyramid of IBD. And, at the top was surgery. And so there's this idea that surgery should be the last resort only after you failed every medical therapy. Numerous studies have shown good prognosis following colectomy and IBD. We'll look at a little bit of that later. And in the modern era, we don't often think about this with surgery, but we really do promote more of a top-down or at least individualized therapy for IBD. So rarely are we doing the traditional step-up therapy anymore. And the future, I think, is going to be more individualized therapy based on potentially biomarkers about how you will respond to what medications. So while it's historically interesting and we should all know it to have some context and a framework, we don't actually practice in the confines of the pyramid. Well, what are the goals of surgery? First and most important, and we should never forget this, underestimate this, but to improve the symptoms and quality of life. So you have to understand what the person's quality of life is on medical therapy or on no therapy to have a sense of if surgery is going to be right or not. Obviously, there are times when you cannot avoid surgery, and many of them include complications, such as perforations, obstructions, or cancers. Salvage for the acute refractory disease. So this is a little different than your outpatient medical refractory disease, but in a hospitalized patient, we have very limited options, and there's a time when you are presented with fulminant colitis and surgery is appropriate. And then with UC, there's a sense that you can cure ulcerative colitis by removing the colon out, and I think it's a cure with an asterisk. It does remove the colon. We certainly know some people will progress eventually to develop Crohn's disease, and there certainly are issues with pouches, which you are well aware of. So if you read anything about timing of surgery, you're going to come across a sentence that looks like this. The decision to operate remains a difficult one that should involve the doctor, the surgeon, the patient, and family. The decision for surgery needs to be jointly assessed by the GI doc and the surgeon. The decision is difficult and should take into account all the pros and cons of a nice planned surgery to what may be achieved by medical therapy. So, unfortunately, there's no silver bullet, there's no magic bullet. Really, it comes down to having an experienced IBD doctor, an experienced IBD surgeon, and a discussion with those two people and potentially more and the patient and figuring out what is best for your patient. So what things do we use to guide us? And I think one of the things is your overall response to medications. This was an interesting study that I thought illustrated this point well, and that there is a law of diminishing returns with subsequent medical therapy. This is particularly looking at one of the anti-TNFs, golimumab, that because of when it was approved by the FDA is frequently used, if at all, as a third-line therapy. And the company wanted to sort of demonstrate that it is actually good as first-line therapy, but because by the time they got approved, many people had already been on infliximab and adalimumab. And so you can see when used as first-line therapy, a high number of people respond, goes down a little bit as second line, and by the time you get to third-line therapies, there's a substantial decrease in the response rate. Now, 50% response rate may still be reasonable to think about, but you do have to realize there is a law of diminishing returns with subsequent therapy. The data for Crohn's disease is a little messier, and this you can see that no matter what anti-TNF you used as a first line, there were sort of similar response rates. For second-line anti-TNF, infliximab actually did better than the others, and these are not randomized trials; these are retrospective cohorts. Whereas the other two anti-TNFs for Crohn's sort of were the same, or maybe worse as a second line. But by the time you got to your third anti-TNF, it didn't matter what it was. The third anti-TNF was about 50%. And I think that the story here is very interesting, and this is a little more on the medical side, but that is an axiom of mine that if if our fellows rotate through my clinic, you'll often hear me say is you haven't failed the anti-TNFs until you failed high-dose infliximab. And I think there's a reason for that, and the real reason is that we have to be more thoughtful of mechanistic failure of response. What do I mean by that? So I mean that how you're failing a current therapy is going to dictate how you're going to respond to your next therapy. So if you take a group of people that are losing response, a group of people with Crohn's disease who are losing response to infliximab, and look at the first column here where they have antibodies to infliximab. And if you were to follow the blue bar there and increase their dose of infliximab, very few people will have a response. However, if you change to another anti-TNF, almost 90% of people will regain response. So in the presence of antibodies to infliximab, changing anti-TNFs, widely successful. If you have a low infliximab concentration and you dose escalate them, the majority of them will have a clinical response. Whereas if you just change the anti-TNF, so in theory, you're going to a subcutaneous anti-TNF after that, you're unlikely to be getting higher levels with a subcutaneous anti-TNF than with a IV one, and you don't see a very good response. So the lesson here is that understanding how people are failing should really dictate what you do next. We also, this is almost so obvious it's kind of hard to show, but you do better if you have an elective surgery versus an emergent surgery. Now, this is a little old data. This is, pre-anti-TNF era, large claims database out of England, looking at whether or not people survive longer, so this is survival benefits, after an elective colectomy versus no colectomy or emergent colectomy. Obviously, there are huge issues with selection bias here, but I think it does illustrate that there maybe is a point at which that emergent surgery would have been elective, and perhaps people would have done better in that situation. So thinking about earlier intervention may be better than later intervention or no intervention. I think there was a really important study in the Annals of Internal Medicine in 2015 that actually has changed my thinking on ulcerative colitis a little bit, and that's surgery for advanced ulcerative colitis. Well, they defined advanced ulcerative colitis as having one of three components: being hospitalized for ulcerative colitis, being on 2 or more courses of oral steroids for over 3 months, and any use of immunosuppressants. I think maybe the last one is a little overreaching, but the first two I think are important. And what you see here is that when you look at the overall general population, there's no difference in the mortality rate. While it looks like the medical therapy does a little worse, the confidence intervals are crossing. We can't say anything with certainty. There's no statistical difference. When they started looking at subgroup analyses, which have all the caveats of subgroup analyses, they said that, well, actually people who over 50 had a mortality benefit from early surgery. And I think it's as important to put in the context, people over 50, is it better to suppress their immune system with ulcerative colitis, or is it better to discuss early surgery? Obviously, people over 50 are quite heterogeneous. Some people will likely do very well with immune suppression. Some people are maybe more frail and maybe should be thought about for surgery earlier. So with ulcerative colitis, you really have to balance the pros and cons. I think there are some options that really push us towards surgery, and dysplasia is one. There's an asterisk there. We're going to have a talk in a couple 2 talks later, I think, about the management of dysplasia. And certainly there's a lot we can do endoscopically, but I still think anytime you are seeing someone with dysplasia, you have to at least think about surgery, talk about it to the patient, even if you pursue endoscopic resection. This idea of advanced ulcerative colitis, perhaps we should be weighing a little more for surgery. If they need other immune suppression, we have a very high transplant population here. And so at what point, are we going to stop immune suppressing these people? And there really is serious infections that come up with, 2 or 3 immune suppressants. They're systemic. And then I think that age greater than 50 is one that I do pause and I at least think about it. Medical therapy, you really want to consider the nutritional status, the fitness, the readiness for a palatorostoma, which really gets back to their quality of life. Will their quality of life be improved with surgery? And then fertility concerns. We'll have a talk later about inflammatory bowel disease and fertility, but it is a concern in our younger population. As with most things, Crohn's disease is a little more complex. Ulcerative colitis sometimes seems more cut and dry, although certainly can be its own beast. Crohn's disease rarely ever seems cut and dry. So factors we need to consider are your phenotype. Now, we know there is a lot of overlap between these phenotypes, but still, most patients can be generally classified into one of the 3 main phenotypes of inflammatory, penetrating, stricturing. Their prior disease course, over and over, I've found that people's history is going to be the best predictor of what they're going to do next. I often tell people I have no crystal ball, I can't tell you what's going to happen, but based on what's happened, we can make some predictions about what things will be like. The extent of bowel involved is really important. My impression, certainly being of a little younger generation, but my impression is that we're seeing less short gut now, and I think that has to do with more aggressive medical therapy. I still have some patients who have had a long-standing Crohn's disease diagnosed in the 80s who do have issues with short gut, but I think knowing their bowel involved does sway me to whether or not I want to be more aggressive medically or not. Their compliance to medical therapy needs to be assessed, although compliance after surgery is also incredibly important. And then this idea that certain people may benefit from getting into surgical remission and then maintaining medical remission. We often in the IBD world think about breaking remission up into induction of remission and then maintenance of remission. And we sometimes use different drugs, example would be steroids, to induce remission, but we would never use steroids to maintain remission. Some have argued, well, perhaps we can use surgery to induce remission and then use less immune suppression to maintain remission. And for some people, I think that is right. And then obviously there are some well-described risk factors for postoperative complications, the vast majority being smoking. So I think that actually a patient's smoking status should be really well thought about before making a recommendation for surgery. And I put this question mark of use of serologies. Every now and then this pops up as being potentially predictive of postoperative recurrence or of outcomes following surgeries. In my practice, I'm not using serologies except for very, very rare instances, and I've never been fully happy with the answer. So I think Crohn's disease is best thought about by cases because there's so many ways this could fall out. And so the first case will be a 69-year-old female diagnosed with Crohn's disease after being hospitalized for abdominal pain. Generally we know that medicines are not very good for abdominal pain, so you got to figure out why she's having abdominal pain. And the real question that you need to answer in this patient is, does this patient have a cold stricture? A cold stricture is what we think of as a non-inflammatory stricture, would not have a CRP elevation in the absence of obstruction. And on enterography, our preference here is MR enterography with our radiologists because I think we get the best evidence for stricturing disease. We can do these live sequences that show us whether or not it's just a little bowel that's not opening up or whether it really is a stricture. And if there's a cold stricture, and this woman has had maybe her disease for 10 years or so, likely surgery is the best option for her. And then just watching her medically is the best thing. But there's a lot that goes into that decision-making. What about a 22-year-old male who presents with an ileocecal fistula and an abscess? So I was just at the ACG conference in Philadelphia, and they were talking about when to do surgery. And everyone there seemed to agree that basically if you have an abscess, you should do surgery. And I think that is often the right answer. And what I generally want to know is there a stricture hidden in all of that? And is there a stricture that has led to a prestenotic perforation and an abscess? Because if that's the case, then you do want to do surgery. There are times when you can treat through an abscess medically. But again, similar to the first patient, I think you really want to know, is there a stricture? And now what about a 45-year-old female with Crohn's colitis who's failed 2 anti-TNF medications related to antibody formation? This is someone I would strongly argue, even though we're getting to our third line therapy, that we would want to continue more medical therapy and optimize her therapy to prevent antibody formation. It may require dual immune suppression, but this is someone I would not want to send to surgery early. 2 cases I've come across since I've been here, which I think were similar and had very different outcomes, and I think kind of illustrate this point, and these are really thought experiments, is these 2 young women. So a 25-year-old female who was initially hospitalized with a right lower quadrant phlegmon. She was treated with adalimumab, improved initially, but then ended up being lost to follow-up, non-compliant, was off her medications, came back into the hospital about a year later, now with a sepsis and an abscess, and was taken to surgery. And was actually presented at a surgical conference, and everyone said, why was this patient not taken to surgery initially? And there was a good discussion about maybe she would have done better with upfront surgery. Then we had another woman, pretty similar, who had a right lower quadrant phlegmon with an anterior vesicular fistula. She was treated with infliximab and had resolution of all inflammation and actually healing of her fistula on imaging. 2 years later, developed antibodies to infliximab with a mild to moderate flare, but actually responded very well to adalimumab and maintains remission with adalimumab. So these are 2 similar cases. They both have ileal colonic disease, severe inflammatory burden. One ended up going to surgery, and maybe that was the best thing for her, although I think there's still a strong argument to be made that she is likely to have more issues in the future. And number 2, she is still likely to have surgery at some point, and maybe we're just delaying and not actually avoiding it. But you can see the complexities of these issues and why, in the end, anytime you read something about the timing of surgery, you see some generic statement about these decisions are difficult and need to have them with an experienced gastroenterologist, surgeon, and the patient. So really my take-home points are that surgery should not be considered a failure of medical therapy. It's actually part of our treatment, and the timing should be individualized based on patient factors. There's a number of situations in which early surgical consultation is appropriate, potentially advanced ulcerative colitis, concerns with systemic immunosuppression, strictures, and then the idea of inducing a surgical remission followed by medical maintenance. As I said, in the end, it is really a team approach. You have to have the patient, the gastroenterologist, and the surgeon, all who have experience making these decisions to figure this out, and there's just no easy way to do it. And I'm obviously very proud of the IBD team that I work with, which does include gastroenterologists, colorectal surgeons, psychologists, pharmacists, nutritionists, and I can say we do talk about these patients ad nauseum. Probably surgeons block me on their cell phones sometimes because I constantly text them and try to update them and twist their arms one way or the other. But that is the end of my presentation now. And do you want to do questions now or later?
Yeah, let's do questions now.
Okay. It's a little case by case. Some cases I think do fall into that, particularly second opinions. A lot of patients, with the limitations of getting medical records, they don't sign their release until they're in the clinic, and so you learn almost why they're there as they're there. But I would say most of these complex IBD patients do end up going to our multidisciplinary IBD conference. And I think that's where we make the best decisions, is where we have the radiologists, the pathologists, and the surgeons and the GI docs all in the same room, all talking about our concerns, all making arguments one way or the other. Yeah, it's tricky, and I think my first thought is once I've exhausted the FDA-approved medications, when we start going down that rate, is you really have to have a conversation, and I do really strongly encourage, and most people do this, have an opinion with the surgeon at that point. Because I think the important thing that is hard for patients to understand, I think a lot of patients think that these are going to work. And you have to explain to them, look, the reason that they're not approved by the FDA right now is that we just do not know. The chance that they work is as equal as the chance they don't. It's not that there are these magic therapies we're withholding from you. Probably the one we have the least success with is hyperbaric oxygen. I have a few Crohn's patients that really want to get hyperbaric oxygen therapy, and there's always some exciting pilot data from a single center that did 10 cases and avoided 7 colectomies, at 3 months, but what does that mean in the long run? How do you apply it to your patient? And so I think sometimes you have to work with the patient. Say, we're going to try it. I'll write the letter. We make the calls, and just meeting the patient halfway is what really matters.